Good evening, everybody. We are on the last Wednesday of April. Incidentally, this happens to be the fifth Wednesday. So we have a very interesting session drawn out with the team led by Brigadier Manoj Kumar from AFMC. He is head general surgery at AFMC Pune. So he, with his team, will be talking to us the peculiar aspects Army faces in surgery. And without much ado, I would like to invite Dr. Pratap Virate, our Vice President, to say a few words as opening remarks. Dr. Virate, please.
Thank you very much, Santosh sir. Respected President ASI, Dr. Pandian, immediate past President, Dr. Praveen Suryavanshi, Honorary Secretary, Dr. Gaddi Diwakar, Honorary Treasurer, Dr. Madhumita Mukhopadhyay, Director Academic Council, Professor Dr. Rajgopal Shenoy sir, Convener International Affairs, past President ASI, Dr. Prabol Neogi sir, Principal Architect of ASI Academics, past President ASI, respected Dr. Santosh John Abraham sir, and all the esteemed faculties, viewers on the ASI YouTube channel. A warm welcome to all of you. I'm extremely delighted that in today's webinar at ASI Time, we are going to discuss a very important topic, that is approach to trauma management in conflict zones and what are the evolving trends in the same. As we all know, trauma continues to be one of the leading causes of mortality and morbidity in the productive population. The ATLS protocol, the recent edition, that is 11th edition, which has changed, shifted from ABCDE approach, which we used to deal with, to XABCDE, and many such newer advances have been emerged in the trauma management, like permissive hypotension, massive transfusion protocol, management of lethal diamond and lethal triad, damage control surgery, and etc. And all these reflect around the physiology before anatomy. And to throw more light on these topics, we have today the accomplished panel of experts from the Association of Armed Forces Surgeons of India, AAFS, one of the important specialty sections of ASI, Lieutenant Colonel Dr. Aditya Pawar, Major Dr. Raj Singh, Major Dr. Dhirendra Yadav, Squadron Leader Dr. Tarun Mohan Gupta. And the entire session will be moderated by Honorable Brigadier Dr. Manoj Kumar from AFMC Pune. So I once again welcome all the faculties and looking forward for the wonderful session ahead, sir. Thank you very much.
Thank you, sir. We move straight away to Dr. Professor Manoj Kumar.
Thank you, sir. Thank you for your kind words. Good evening to Dr. Maruthapandian sir, Dr. Virate sir, all past presidents, office bearers of ASI, my seniors and colleagues. Firstly, many thanks for involving the Department of Surgery at AFMC for the ASI Time discussions. This is the first for us. As discussed by Dr. Virate sir, trauma and conflict are increasingly involving in civilian areas and the common man, as much as they're involving the uniformed forces. And the casualties in most of these terror-related incidents, if you see over the past decade, they're also more skewed towards the civilian fronts. The role of surgeons also in general is increasing as a team leader, medical command, performing triage over and above his treatments and transportation of patients to the hospital. So keeping this in mind, we've selected this topic of an approach to trauma management in conflict zone and what are the evolving trends and how the world has changed over the past some time. We have divided them into 4 parts. That is conflict of today and the need for slide changing. The slides are not, conflicts of today and the need for pre-hospital trauma care, changing scenario, to triage and the role of damage control surgery, CBRN threat, that is chemical, biological, radiological, nuclear, and perhaps electromagnetic threat, what to expect and how to prepare. And lastly, at the conceptual level, the role of civil-military coordination key to mitigate trauma burden. We have four very young, enthusiastic speakers for this topic. But before we go ahead, a common disclaimer for all of us that the views and opinions that are expressed in this talk are that of the presenter and do not in any way convey the stance of any organization that we have discussed. No classified or restricted information of any kind is displayed or discussed. Only information that is available on public domain, open media, or internet would be discussed. With this, I'll request Scholar Tarun Mohan Gupta, our faculty in the Department of Surgery, to start with the pre-hospital trauma care requirements in conflicts of the date. Tarun, please.
Thank you so much, sir. I would, on the starting, I would thank all the faculties, my seniors and my colleagues for this opportunity. The topic that I'll be covering is the wars of today and need for pre-hospital trauma management. What is hybrid conflict? Basically, hybrid warfare is a military strategy that in which there is a synchronized use of diverse range of operations and irregular tactics to achieve some strategic goals. This approach blurs the line between war and peace and between state and non-state actors operating in a gray zone. A military strategy that involves the synchronized use of diverse range of conventional military operations and irregular tactics. This term, hybrid warfare, dates back to 2007 when Frank Hoffman first mentioned about this. And thereafter, it has now been used in various wars, like the Chechen War from 1999 to 2009. Thereafter, the Syria Civil War from 2011 and continuing till present, the Tigray War in Ethiopia. But it seems that such attacks are deployed systematically on an unparalleled level in Ukraine. So what is the difference between the conventional warfare and the hybrid warfare? There's an increased use of drones, and now the strikes are targeting the urban areas more than the war zones that were previously targeted. The standards have been changed, and mass casualties can be experienced by city hospitals, which majorly have the wartime casualties. Obviously, the civilian population as well as the civilian hospitals are not geared up for wartime casualties. Neither they are trained, neither the paramilitary counterparts are trained regarding this. So this anomaly has to be dealt with. And an unpredictable evacuation timeline also exists. Because of the drone attacks, it will become very difficult for the casualties to move by road or by air to the nearest tertiary care center. In such a scenarios, other modes of transport has to be used, and also an on-ground effective management of casualties needs to be addressed and started with. The golden hour in trauma, which deals with all the serious injuries in a very prompt and necessary manner, is now no longer guaranteed in case of hybrid warfare. There will be delayed evacuation. Therefore, the shift to prolonged field care has become a necessity. The need to extend that resuscitation window is also an immediate thing that has to be addressed. There was also the concept of the platinum time of 10 minutes, in which the casualty has to be evacuated within the 10 minutes of the emergency team reaching the casualty. This no longer can be confirmed and cannot be managed in that manner. Now, what is the pre-hospital trauma care? Since civilian targets are more prone to such kinds of attack, so pre-hospital trauma care, for doing a pre-hospital trauma care, the paramedical staff has to be trained more than the hospital staff. This will prevent any preventable deaths and also help in stabilizing patient until the definitive care can be subsequently given. This also maintains the physiological reserve and prevent the lethal triad of death. The earlier concept of scoop and scoot was used by the combat scenarios and also in the rural scenarios. Now, the rapid transport, since cannot be guaranteed, we have to shift to another maneuver. That is the stay and play. That is the which is critical in the aerial threat scenarios. In this, as the new ATLS has rolled in, the hemorrhagic control has to be dealt with first. My colleagues will discuss about this in more detail, in which the hemorrhagic control has to be done using tourniquets. The airway has to be secured using the supraglottic devices and surgical airways. The breathing, depending on the scenarios, has needle decompression can be done at the time and at the place of injury. The circulation has to be started using the IV or the IO access, and blood products now has to be provided at the scene of injury rather than at the tertiary care center. Hypothermia Hypothermia prevention is also one of the need that has to be dealt with at the same time. The prolonged field care refers to delivery of advanced care at the site of injury. The goal of such prolonged field care includes sustained life beyond the golden hour and preventing the deterioration of casualties which are salvageable. Its components include ongoing monitoring at the site where the casualty has taken place, giving analgesia and sedation, giving antibiotics, fluid and blood resuscitation, and definitely the wound care. What is cadre building? In cadre building, we train the non-physician personnel, which includes soldiers, paramedics, first responders, drivers, and policemen. They can have a little bit of medical knowledge or maybe completely untrained. These now, these people now have to be trained so that if such a scenario arrives and such a trauma and mass casualty scenario is being has to be dealt with, then these people are ready at the behest. In this case, immediate first response might save lives. In the resource limited scenario, they will treat the patients at the site of injury. The care will be continued and it will reduce the preventable death. What is modern warfare and health? Since the start of this ongoing Ukrainian war, there has been incidents when the healthcare system and the ambulance services have been targeted. WHO also has given all data in which it has said that almost 91 hospitals and 24 personals, including around 170 patients, have died while they were going on the way to a tertiary care center. So since attacks on healthcare facility and ambulance services are taking place, mass casualty events are taking place in urban zones, we have to be geared up and not wait for such a scenario to hit us before we start with taking adequate measures. Why surgical readiness matters? Coming to the surgical aspect, during such scenarios, we can expect large number of casualties and timely surgical interventions would be required. In such a scenario, logistics and the protocols, if in place, will save countless lives. During hybrid attacks, most common injuries that we might be able to see would be crush injuries, blast injuries, penetrating trauma. Though ATLS also teaches how to take care of such injuries, but it goes on with a triage concept. In mass casualty, in case of hybrid warfare, the chances of red zone injuries can be very high. So we already have to we have to gear up for that. Also, there would be CBRN attacks that can occur. And in such a scenario, how healthcare workers need to perform their duties, that has to be, the healthcare personnel have to be trained for that. The concept of mobile and modular surgery has been there for quite some time. Even in India, the Arogya Maitri Cube has also been deployed at multiple places, especially in Sri Lanka. My further speakers will also throw light on how it is done. But this Arogya Maitri Cube can be deployed within 12 minutes. And after deploying it, the care can be given to countless casualties at the site of injury. Similarly, other kinds of modular OTs can also be taken from other countries, which can be then deployed in various cities and transferred to the areas where casualties are occurring. Cyber attacks have also happened in the past. You must be knowing about 2-3 incidences that occurred in US, in which the OR had become non-functional and wrong reports were being forwarded and wrong blood groups data was being given to the lab. This also led to 2-3 deaths in one of the hospitals in the US. So we should not wait for such a scenario to happen in India and have to gear up for that. And we have to make a robust system of paperwork that can flow during such times. The modular damage control surgery kits have already been there. If you can see on the slide, there is an image on the right lower corner. This is a wild OR kit that has been developed in Texas, which is the sterile kit with a place for keeping the instrument also on that kit. And this can be readily procured and placed at the site of surgery. For all the casualties, a separate kit can also be used. We have already been using such kind of kits at our level in the defense forces at combat zones. Coming to the strategic takeaways from my point of view, hybrid warfare stresses mostly on the surgical systems because all the trauma will mostly be surgical. So readiness requires mobility, resilience, and a good connection between the civilian and as well as the uh, armed forces. So integration is required at all levels so that we can make sure that such kinds of scenarios can be dealt in a better way. Now I'd request Dr. Dhirender to take over and continue with the presentation. Thank you.
So Tarun has emphasized on stay and play in face of prolonged field care, and the healthcare facilities no longer being taboo for the enemy and they're likely to come into attack. And also the availability of cubes and BISH, and the fact that HIS is also, that is hospital information systems, are also prone for cyber attacks. So this, I think, would be the changes that have occurred over the past decade or so. Dhirender.
Good evening, sir. Good evening, Chairperson and respected faculty members. I am Dr. Dhirendra Yadav, and I'll be discussing a topic that lies at the very core of the modern trauma, that is triage and the damage control surgery. This is not just theory. This is what determines who lives and who doesn't in the very first and few critical hours after the trauma is sustained. Let me begin with the scenario. Supposedly, we have a 28-year-old male polytrauma after a high-speed road traffic accident, and he's arrived at the emergency center in a hypotension state, tachycardia, and altered sensorium. And at the very same time, we have 3 more patients in the emergency room. So now who do you treat first? Do you proceed with a definitive surgery or stop early? What is the answer? The answer is triage and damage control surgery. Triage is defined as the process of prioritizing trauma based on the severity of injury, the physiological derangements that are present, and the resource availability to maximize the survival probability of the patient. Let me emphasize, it is a dynamic process. It is repetitive and has to be performed multiple times. And the core ATLS principle in this is that treat the injury that is the threat to life first. Triage is mainly done in 3 settings, that is the primary triage, the secondary, and the tertiary triage. Primary triage is mainly at the scene of the injury, wherein it is supposed to be conducted at the site and it is supposed to be rapid. It is focused on who do we have to transport first. The secondary triage is performed at the emergency department or at the site where we are at the receiving end in the hospital. This includes a detailed examination of the physiological status and the anatomical abnormalities that have been there. Whereas the tertiary triage is the ongoing process wherein we continue our treatment, we continue the repeated assessment so as not to miss any injuries or the physiological deterioration of the patient. Over a period of time, what has happened, there has been a changes in the protocols of the ATLS. They have now shifted from ABCDE to XABCDE, wherein they emphasize that the exsanguinating hemorrhages that are present are to be addressed first because they are now assumed to be the first killers of the patient in trauma setting. What are the goals of trauma triage? They are very obvious, but are critical at the very same time. The aim is to identify any life-threatening injury, to allocate the resources available to us efficiently, and to ensure that appropriate level of care is given to the patients depending upon the resources available, so as to attain a reduced mortality in cases wherein it can be prevented. What are the various triage categories? As we can see, the triage is mainly the red category, which is the immediately life-threatening but are salvageable. And as coming to the minor injuries, they can be categorized into the green, wherein the patients are walking wounded. ATLS-based triage decision framework is mainly dependent upon the physiological, anatomical, and the mechanism of injury that is involved, wherein the physiological criteria takes the priority because they are supposed to be the most important and the most lethal if not cured on time, sir. What are the errors in triage? What we see is while allocating and while giving the primary care, there can be scenarios wherein there is under triage, wherein we fail to identify the injuries that are severe and hence lead to an increased mortality which can be prevented. And what is over triage is when we do the triage excessively so as to cause a burden onto the resources that are available and also the healthcare system. This concept of triage and damage control surgery has evolved from the physiological status, wherein we see when the patient has undergone an injury, and thus, as a result of the hemorrhage, there is a lethal triad that occurs of the coagulopathy, the hypothermia, and the acidosis, which later on leads to mortality. Where did this concept initially came from? Early treatment, early total care was the initial concept which was being followed historically since the time. But what we had seen that if we go on to a definitive care in the very first setting, what used to happen, the mortality rate was high because of the setting up of the lethal triad. Then therein came the concept of the damage control surgery. So now we have various criteria wherein we can define what patients we can take for early total care and what patients we can take for damage control surgery, wherein the key concept of this is the venous lactate level. There are literature that suggests that early total care can be initiated for patients who have a lactate level of less than 2 millimoles per liter. And it is not at all advisable for patients wherein the serum lactate is more than 5 millimoles. Damage control surgery. This concept came from the US Navy, wherein their aim was when the naval ships are on sail and they are under war threats. What is the concept we'll follow? Supposedly the ship has a trauma. The concept was to do a minimal repair so as the ship keeps on functioning and they survive the war. So similarly, the surgical team has also taken control of this concept and they have come to a decision wherein the damage control surgery is mainly aimed at controlling the bleeding, controlling the contamination and restoring the normal physiology of the patient so as to improve the survival rates. The main indications are presence of persistent hypothermia, persistent metabolic acidosis, and coagulopathy. What are the various stages of damage control resuscitation? They've been mainly classified into 5 stages, starting from the patient selection in the pre-hospital era and going up to a definitive abdominal closure or a definitive treatment. The first phase is the pre-hospital and the hospital care, which were built on the fundamentals of the ATLS guidelines, and this is where the triage will come into role. Our aim is to transport the patient to a definitive center as early as possible, and even in the casualty or the emergency department, we aim at resuscitating the patient as hastily as possible. Then we come on to the phase of damage control resuscitation, where it will begin with this use of tourniquet to control the bleeding. If at all the transfusions are required, then we have to transfuse. The use of crystalloids and colloids are usually means they are in a controlled setup, and the use of blood products is more advised because then there are least chances of hemodilution and further the triad getting into activation. The aim of DCR is to keep a patient in the permissive hypotensive state, and also it is advisable to use various hemostatic agents. The US military guidelines for damage control resuscitation have been flashed onto the screen, wherein there are various criteria that have to be met so as to support the healthcare team, wherein to bring in the role of the damage control resuscitation. These are the various guidelines so as to support when the damage control resuscitation is to be stopped and when a definitive treatment can be given. So this is the role of the damage control resuscitation in the initial stage, wherein we aim that the permissive hypotension should be ideally between the systolic BP of 70 to 90 mm of Hg, because greater, if we aim at a higher pressure of more than 90 mm, then there are chances that the bleeding may occur. And similarly, there is a concept of balanced transfusion, as I've already told, that more of the blood products are to be transfused in such situations. What is the concept of phase 2 or the abbreviated laparotomy? Our aim is to take the patient to a minimum duration of surgery and do the maximum effort that is possible so that the physiological status is restored to the best, wherein the anatomical reconstruction is not that main aim. Physiological status is the more better or the main aim which is to be controlled, wherein the DCS in terms wherein abdomen is concerned, we aim that the hemorrhage is controlled. If there is any contamination, that we control and debride the all dead or the revitalized tissue that is present. These are the various photographs that I've been used and the concept of abbreviated laparotomy, wherein the closure of the abdomen is not that big an issue. We temporarily close the abdomen and try to achieve the maximum possible result that is possible. You can see on the left, there is the usage of a Bagota bag and the negative pressure wound therapies that have been used to temporarily close the abdomen in such scenarios. After the phase of the damage control surgery, then comes the main stage of the ICU resuscitation. This is the main stage wherein we've already tried to restore the damage that has been done as minimal as possible with the best possible result. And now we aim at the resuscitation so as to get the best results. The goal of this ICU resuscitation is that we reverse the sequelae that is happening and the related metabolic acidosis to restore the physiological and the biochemical parameters of the patient. We ensure that there is adequate oxygen delivery to the tissues in the body, and then we keep the patient under intensive monitoring. After this phase, once we've achieved the ICU resuscitation and we've met the parameters of the damage control resuscitation, that is where, if required, we can go ahead for a relook and a definitive surgery, and otherwise we can go ahead with the definitive abdominal closure. We would conclude the DCS timeline as follows, sir, wherein the main problem which arises is the initial phase from the injury to the arrival of the patient in the emergency department. This is the phase wherein maximum delay happens. Otherwise, from the resuscitation will begin from the emergency department, and our aim is to take him to operating room as soon as possible. Go ahead with the damage control surgery, do the minimum that is required to get the best possible results, and then go ahead with the ICU resuscitation. And once we feel that the patient is improving hemodynamically, then we can go ahead with the relook surgery. And if the patient is stabilizing, we can further go ahead with definitive abdominal closure. In the end, I would like to conclude my presentation with the main three take-home messages that triage is according the priority. Triage is what will decide what patient goes first. X, A, B, C, D, E is the main concept of the ATLS, which will save lives in the initial hours of trauma. And during the resuscitation, physiology is what takes priority over anatomy in all unstable patients. Thank you, sir.
Manoj sir, you are muted, sir. You are muted, sir.
Thank you, Dhirinder. That was a very nice presentation on your side, crisp and concise.
Patient का option कहाँ आता है इसमें?
The third speaker we have is Major Raj Singh. He'll be speaking about CBRN threat, that is chemical, biological, radiological, nuclear threat, and what to expect and how to prepare. Raj.
Sir, I'll start my presentation, sir. So, are my slides visible, sir?
Yeah, your slides are visible.
Sir, good evening, everyone. I am Dr. Raj Singh, Senior Resident in the Department of Surgery, Armed Forces Medical College, Pune. And today I'll be speaking on CBRN threats, how to prepare and what to expect. Sir, today this is an increasingly relevant topic, not only in warfare, but also in civilian disaster preparedness. And also in civilian disaster preparedness. Now, I would like to show this image, sir. This image is famously titled "The Terror of War." It was clicked in 1972 after napalm bombing of a village in Vietnam. You can see people running around in the roads with second and third degree burns. So basically, this photo won the Pulitzer Prize a few years later, and this reflects the devastating human cost of unconventional warfare. So CBRN threats, which are basically chemical, biological, radiological, and nuclear, these threats are unique because they cause mass casualties, panic, and long-term consequences, often beyond immediate medical control. Now, an important point to understand is that there is no international universal treaty that completely prohibits the use of nuclear weapons in conflict. Threats can arise not only during war, but also in peacetime through nuclear accidents, radiological dispersal devices, improvised nuclear devices, chemical weapons, toxic industrial chemicals, and biological agents. So this is not just a battlefield issue. It is also a public health issue and a disaster management concern. The CBRN incidents present unique challenges. These challenges include difficulty in early recognition, the presence of invisible agents, risk of secondary contamination, requirement of specialized equipment and training, and the possibility of overwhelming number of casualties. These factors make response complex and time sensitive. History has shown us the impact of such events from World War I chemical attacks to modern-day industrial disasters. These incidents reinforce one key lesson: preparedness and early response to save lives, like the incident that happened in Tokyo in 1905 to the recent incidents like Novichok poisoning of a Russian citizen, and a fairly recent incident which happened on February 7, 2026 was the mustard gas leak near Jammu airport, in which CBRN forces were mobilized to control the event. Now, how do we recognize a CBRN incident? We should suspect it when we see increased number of cases, sudden arrival of multiple patients with similar unexplained toxidrome. There will be various signs and symptoms of non-flame burns. Patient can have neurological symptoms in the form of altered consciousness. Their patient can have GI symptoms in the form of nausea, vomiting. Patient can have flu-like illnesses. There will be large number of cases in shorter duration. There will be history of exposure to some chemical or some kind of some exposure. Then there will be chemical exposures complicating airway and respiratory management. So what would be your first step as a primary medical care provider after recognizing a CBRN incident? This is triage. Now, in practical terms, this means appropriate personal protective equipment depending on the route of exposure, moving upward to a safer zone, establishing hot, warm, and cold zones, stopping eating, drinking, or smoking. Sorry, sir. Stopping eating, drinking, and smoking. And these steps protect the patient and the responder. So there are various principles. First is recognition, that is detection and diagnosis. Second is safety, personal and collective protective measures, self-aid and first aid, casualty assessment by quick look, performing life-saving interventions, casualty hazard management, then providing advanced medical care, and ultimately the rehabilitation. This, in practical terms, we should basically follow these principles. Now, there are 6 C's as a primary responder that we have to follow. These are, first one is confirm. Confirm that there is a CBRN incident. And first of all, we have to protect ourselves. The primary care provider, they have to protect themselves by using personal protective equipment to avoid possible routes of exposure like airborne or skin exposure. Second one is clear. We have to move upwind from the direction opposite to the direction of the wind. We have to move to a safe zone. Then the next one is cordon. We have to establish hot and warm zone. That is the decontamination zone. Then we have to control. We have to stop any eating, drinking, or smoking, or any other thing by which by which those things can spread. Then we have to communicate. We have to inform the local medical authorities regarding the incident, and we have to keep everybody in picture. Then the next thing is contain. We have to prevent secondary contamination. Now, triage is absolutely critical in CBRN scenarios. The patients are classified in various categories as visible on screen. That category T1 is the patients which require immediate life-saving interventions. T2 patients are those which are delayed. They are basically stretcher casualty, but not requiring immediate life-saving interventions, or casualty which is incapacitated either physically or mentally. T3 is minimal. The patient is walking and not incapacitated. T4 is expectant, and T5 is dead. Now, a quick note, the term triage was coined by the Baron Dominic Jean Larry. He was the surgeon to Napoleon's army. And the first documented example of CBRN attack was actually in World War I, when the Germans used 150 tons of chlorine gas against French at Ypres on 22nd April 1915, which was shown in the movie Wonder Woman. And the agency looking after CBRN incidents in India is National Disaster Response Force. Now, what is the role of quick reaction medical teams? For the quick reaction medical teams basically establish decontamination center. They triage the casualties. They perform the decontamination of the casualties, and they evacuate the casualties after primary treatment decontamination to the tertiary care centers. The quick reaction medical teams, especially under the NDRF, play a vital role. They are responsible for the initial medical response, stabilization, coordination of evacuation, setting up forward medical post. These teams include medical officers, nursing staff, paramedics, and they function based on the factors such as wind direction and contamination spread. Now, casualty management follows a structured pathway. This includes removal of contaminated clothing, decontamination showers, monitoring, triage, transfer to clean zones, evacuation via clean ambulance to higher centers. This process prevents further spread of contamination. Now, as you can see, from after receiving the casualties are taken to decontamination and treatment center. Now, the decontamination center has got paramedical staff, and in the treatment center, there is medical officer. They also established forward medical post at the front and in the hot zone. The approx composition of QRMT is as follows. At the ground zero, that is the contaminated area, they establish forward medical post housing the paramedical staff. Then there is decontamination center, again with the paramedical staff and general duty staff. Then the casualty is brought to treatment center, where a medical officer is housed, and along with nurses and general duty staff, and from where the patient goes to the tertiary care center. On the screen on the left of your screen, you can see the direction of the wind is opposite to the transfer of the casualty. Now, CBRN casualty and decontamination and evacuation. First, we established 3 zones. First one is a hot zone. then a warm zone, and a clean zone. In hot zone is the area where the incident has occurred and where the casualty has been found. So from the hot zone, the casualty collection and triage happens. They are forwarded to the forward medical post. The forward medical post can be either any PHC, any UHC, or a civil OPD from where the casualties have been received. From there, they are taken to decontamination center, where garment removal, decontamination shower, either plain water shower, patient monitoring, first aid is given. Then the patient is transferred to a clean zone, that is the treatment center, where definitely treatment will be given. And from the treatment center, evacuation of the patient is done by clean ambulance or by air to the final CDC, that is the clean treatment center or the tertiary care center. This is the image showing the decontamination center. The image, the first image on the left upper image is the one where the casualty is being brought to the decontamination center. The second image shows the decontamination shower, and the third and fourth image shows the treatment center where the casualties are getting treated. Now, how do we manage such casualties? After providing first aid, when suspecting a CBRN incident, first of all, the pre-treatment is given by using NAPS tablet. These are pyridostigmine tablets, basically against the nerve agents. Then on exposure, there is a auto injector. There is a self injector which is given, which contains atropine and PAM 600. Then the decontamination happens, and then patient is evacuated. The management of the casualty includes pre-treatment with all these things. Each responder, whoever is responding to the patients, they are equipped with personal decontamination kit to minimize exposure and maintain operational capability. Personal dosimeters are used to detect radiation exposure and measure cumulative dose over time. NAPS or pyridostigmine bromide is used as a prophylactic agent against nerve agents and is administered at regular intervals. The auto-injector set contains atropine 2 milligrams and PAM 600 milligrams and is self-administered at 15-minute intervals upon the appearance of the symptoms, with 3 sets typically authorized per individual. This is the photo showing the personal decontamination kit, which contains the activated absorbent powder formulated against the chemical warfare agents. The other one contains radiation decontamination paper. This contains a sachet with wet napkin soaked in decontaminant solution for physical removal of any radioactive particles from the skin and other articles. Then the photo on your right also shows a paper which changes the color on exposure to the particular kind of agent. Then the personal dosimeter. Personal dosimeter is something which detects gamma radiation and neutrons and detects only cumulative dose of exposure. Now coming on to the training requirements of manpower in CBRN situation. Since training is always essential for effective response in India, institutions such as Defense Research and Development Establishment at Gwalior, the Institute of Nuclear Medicine and Allied Sciences in New Delhi, and the Defense Laboratory at Jodhpur provide specialized training. We basically need coordination between different medical echelons to effectively manage the casualty. The training of selective medical officers and paramedical staff should be done in future to basically mitigate such situations if arrive. And training and coordination between various echelons will definitely help us in casualty management in future. Now, the key takeaway points, and to conclude, triage is the key to saving lives. Early recognition is critical, and propagation of knowledge is essential, and is essential in such scenarios. Now, I would like to ask the next presenter to please take on the stage.
Thank you, Raj. I think you have emphasized on recognizing the CBRN. Triage here is quite different from the triage that you do in a normal condition, and with an expectant category being significantly large, and the principles of surgery in the presence of radiation.
So,
thank you. Now I'll request Lieutenant Colonel Aditya Pawar to speak on civil-military coordination.
Thank you, sir.
Aditya.
Are my slides visible?
Yeah, slides visible.
Thank you, everyone. The office bearers are the ASI, and for giving us this opportunity. So, as my colleagues have talked about the various medical requirements and the treatment protocols and the scenarios that are there, but in the existing geopolitical scenario, we need to understand that the changing conflict methods, any country can be pushed into months and years of wars. And these conflicts can be long drawn, long hauled. And in such scenarios, with the changing threat, the aerial threats is taking place, which is excessively involving the aerial dominance and the air defense systems. So in these scenarios, it is extremely important that we understand now the conflict is not starting at the borders, is happening right in the cities. So the prime cities become the prime targets, and they are not happening later on, but they happen at the start of the conflict. So with this, we need to understand and we need to emphasize that the civilian infrastructure, the civilian casualties is going to increase. And in view of that, we need to have a very efficient, fluid civil military coordination in order to mitigate the trauma burden. That is what we will reflect upon in the view of the recent border operations that India had. So on 7th May 2025, India conducted Operation Abhyas. Now, this was the largest civil defense exercise that has been done since 1971. So in terms of the scale, it was massive. There were, if we talk about some numbers, there were 244 districts which were involved, in which they were identified on the basis of the threat perception and the important facilities that they harbored. For example, some of them were having nuclear plants, military bases, and oil corporations. So these areas of important nuclear and chemical infrastructures which were housing, they were detailed as the high perception districts. Around 1.5 million of the volunteer base was created to organize these civil defense exercises in which the various aspects of societies and members of the civil walks of life were trained. Students, volunteers, and office goers, they were all trained what to do and what not to do during such threat perceptions. And this training also went ahead and trained the children in the schools and students. And happy to share that around 1.6 million, that is 16 lakh students, were trained during these extensive exercises that happened as Operation Abhyas. So that was a major feat that was achieved. So these pictures are something which was very common during the last year. They were flashing across our televisions, and they all show the various aspects of Operation Abhyas being carried out in letter and spirit. People from all walks of life were trained what to do. Students, officers, railway stations. These exercises were done all over the place. Civil, how were we able to achieve this? This we were able to achieve by using centralized planning. The Ministry of Home Affairs and National Disaster Management Authorities provided overreaching guidance. So there were joint command centers which were organized, which were established at each district levels. There were real-time DEOCs, that were district emergency operation centers, which were established, which were headed by the district magistrates or the additional district magistrates. And there was a seamless information flow from the center to the state to the authorities that was exercised and that was practiced for such scenarios. Multiple agencies were involved, like the National Disaster Management Authorities, the National Disaster Relief Forces, and the State Disaster Relief Forces, police, fire services, National Cadet Corps, National Services Schemes. There were multiple organizations that were threaded into one beat, and the seamless flow of information and exercises were done. In fact, Defense Minister Rajnath Singh lauded these exercises by saying that this is a brilliant example of civil-military fusion. Simulations in the form of air raids and blackouts were done. And I'm sure sirens were a common sightings that particular time. There were deliberate power cuts so that to sensitize the civilian populations to the city members of the civilian societies to how to organize their, how to prepare for such long power cuts and how to carry out their activities. Evacuation drills were conducted in the peripheral areas and village and rural areas where people were shifted to the important shelter, the underground shelters. Drone defense exercises were conducted and air defense systems were validated. Emergency response simulated were carried out at Mumbai's Chhatrapati Shivaji Maharaj Terminal, South Goa's Indian Oil Corporation Limited, and the Margao railway station. So all these things in various setups, in various scenarios were conducted to sensitize the population. This also involved an important aspect was to how to engage the public. Engaging the public could happen with advanced notification, so there was no panic. So the people do not panic. So initially and every time, these people were sensitized through social media, through the conventional media on what the government is planning and organizing. Involvement of technology deployment in the forms of the telecom drilling emergency SMS messages on the phone, on what time are the various drills being conducted, what time are the power cuts being conducted. Citizen guidelines were clearly laid out and community involvement was emphasized and enhanced by the various these organizations like the National Cadet Force, National Services Schemes, and the National Youth Schemes. So with a clarity and some consistency and with calm, we were able to organize these civil military exercises. Outcomes. So enhanced readiness was practiced, was promoted, public confidence was increased following these exercises, and institutional reforms, whatever the gaps were seen, were filled. So during the exercises, what we deployed was again something which has been newly introduced are the Bhishma cubicles. Now, Bhishma stands for the Bharat Health Initiative and Sahyog Hita Matris. These were I will talk about in slightly more detail later. But as of now, Bhishma cubicles were deployed in certain areas. Hospitals were the bigger medical centers, the hospitals of prime importance like the AIMS, PGIMR, and JIPMR. They expanded their casualty beds by almost 40% to accommodate the civilian casualties. And organizations like All India Organization of Chemists and Druggists, they were informed and they were mandated to form and stock drugs of importance, life-saving drugs and blood products in order to provide medical supplies in such scenarios. Project Bhishma, which I just mentioned, is the Bharat Health Initiative and Sahyog Hita Matri. It is an initiative in which we have designed and developed some modular systems of healthcare which can be readily deployed. The advantage of these Bhishma cubicles is that they can be rapidly deployed. There is tech innovation which is involved. They act as humanitarian aid, can be sent to different countries in natural disaster scenarios, and they have an operational readiness which is almost 24/7 deployable units, which can be easily deployed. Now, these Bhishma cubicles, they consist of 2 mother cubes. Now, each mother cube has 36 mini cubes, and each mini cube weighs around 15 to 20 kg, and it consists of important medical equipments, drugs, and other infrastructure components. So it requires almost 12 minutes to get deployed. Once deployed, it can take care of 200 patients, and it is self-sustained to carry out these healthcare activities for 48 hours. It can even perform 10 to 15 surgeries during this 48 hours. So, interesting thing about them, they can be airdropped, they can be carried through trucks, they can be carried through waterways. So, easily deployable, easily transportable, rapid assembly, and they are very tenacious in the form of their environmental resilience, and they have all sort of waterproof, and they are lightweight and robust. That means they can be deployed in difficult terrains, mountain terrains, deserts, anywhere. So provides immediate medical support, as I just mentioned, and airlift has been tested by airdropping them through 15,000 feet, and they have been established at harsher terrains also. So key takeaways that we understand from these exercises that were conducted and deployments of new modular infrastructure is that we need to understand that we have to strengthen the future civil defense capabilities through standardization, technology, and coordination. SOPs have to be established. What sort of conflict are we dealing with? What is the level of escalation that we are looking? And accordingly, what SOPs have to be implemented. So these have to be preformed, and we have to be very deliberate in all this. The training of the volunteers, the civilian training, students, young individuals, and how to help establish volunteer bases. This is extremely important because in long conflicts that the world is presently seeing, it is extremely important that we develop that mindset of catering to casualties, helping our society members, and forming a robust system of the inbuilt community volunteer base. This is extremely important. Modernizing infrastructure by improving emergency shelters and invest in underground infrastructures like hospitals and metros, even civilian hospitals. To some extent, some particular designated hospitals have to be built underground, so that can facilitate in cases of aerial hostilities, that the casualties can be treated. So not just the military hospital, but some thought has to go in to establish underground civil hospitals. Strategic deployment of tunnels and bridges so that the transportation and the casualty evacuation does not get hindered. Invest in CBRN worthy strategic shelters and healthcare facilities. In the present conflict scenarios, we need to understand that we are not just dealing with explosives, we are dealing with CBRN threats. So such infrastructure in every major cities which can cater to certain level of population has to be developed and deployed. Leverage of technology, development and deployment of technology for aerial dominance and defense is important. Sophisticated telemedicine and telerobotics technology for distant casualty management, as we are emphasizing on the scenarios of stay and play. So these telerobotics and telemedicine can be employed. A thought has to go into that, and we have to upgrade our communication network and create safe cyberspace. So, and the last, interagency coordination between various civil and military organizations, public communications involving them, and a legal oversight to respect the international humanitarian law and the various legal aspects of it while understanding and implementing. So at the last, I would like to say that we have to preparedness saves lives, and that is what we need to implement and use. Thank you.
Thank you, Aditya. That was a very nice, lucid presentation, and you have told us the importance of coordination, communication, coordination between agencies, and the need to have infrastructure, technology preparation ahead of schedule, so that we are ready for any of these events or any of these multiple casualties, mass casualties, disasters of whatever nature. Thank you for that. If there are any questions from any audience, I'm sure the ASI team will agree that we have finished it well in time, sir, within 1 hour. So, so if there are any questions, we would be ready to take. Over to you.
Good evening, sir. It was a well-conducted meeting. I would like Dr. Rajgopal Shenoy to come in. Dr. Rajgopal Shenoy, sir. You're muted, yes.
Hello, sir. Yeah. Firstly, my big pranamam, sir, because this is an important topic. Actually, need of the hour. Will say salute to, always typical saying a Jai Jawan, Jai Kisan like. So the working in that battlefield plus injuries and managing, I still remember during our younger days of undergraduate and postgraduate days, the trauma center is something like one fracture center. Let me put it straight away like this. Hardly any general surgeon was involved. Initial days, I'm not talking, those days. So trauma center is fracture center. Then over a period of time, how these things have changed and our understanding of the subject and what it has come to this level from this high speed with this national level, it's a phenomenal changes. Of course, India badly needs plenty of trauma centers. Super highways are coming up. More importantly, pre-hospital trauma care. Because the golden hour, whatever we talk, training the government, not only doctors or something, that's what I think already clear it is, non-government organizations, local people, local police, local volunteers, so many people who are involved in the entire. Sir, thank you very much for the wonderful symposium. Thank you very much.
Thank you, sir.
My pranamams. Salute.
Manoj Kumar and team, there are lots of best compliments in the YouTube channel. No questions are there as such, and everybody is complimenting all your talks. I would like Dr. Reddy to chip in and say a few words. You sound very second.
Thank you, sir. Good evening, everyone. As we understand, this webinar emphasizes the importance of adaptability, rapid decision making, and efficient resource use in trauma care within the conflict zones. All the four speakers presented the need to be prepared, especially for CBRN and the hybrid warfare. An excellent session moderated by Dr. Brigadier Manoj Kumar, and the discussion highlighted evolving trend towards the structured protocols, multidisciplinary coordination, and the use of appropriate technology in challenging settings especially. So I thank all the speakers and the participants. Let us apply these learnings to strengthen our trauma care and save more lives. I also thank the leadership of the Association of Surgeons of India and especially our academic director, Dr. Rajgopal Shanai sir, and Dr. Santosh sir, the brain behind this session, for envisioning and supporting such progressive academic platform. This is the first time we interacted with the armed forces on this platform, and a good job done. And I thank everyone again. Happy evening. Thank you.
Thank you, sir. Last not the least, our honorary treasurer will be proposing the vote of thanks. Dr. Madhumita, please.
Thank you, sir. At the beginning, I thank our Vice President, Dr. Pratap Borute, and our past President, Dr. Probal Nuki, for your valuable inputs. Thanks to our academic advisor, Dr. Santosh John Abram, who's the architect behind this whole program. Thanks to Dr. Shenai for arranging, our academic director, for arranging this whole program. It's actually, what you can say, today you can say this is an example of a civil military coordination or a civil military exercise. Can't we say that? All should agree to that. Thanks to Thanks to Dr. Manoj Nair for a very good moderation. The timing was just wonderful. Each and every speaker just on time, not a minute more, not a minute less. And it's always such a pleasure to hear the armed forces talk. We see you in action, and when you talk, we all listen. Thanks to each of the speakers, Dr. Tarun, Dr. Dhirendra, Dr. Raj, and Dr. Aditya. It was a wonderful session. I learned so many new important things like hybrid warfare, cadre building, abbreviated laparotomy, cyber attacks, then this Bhishma cubicle. I'll definitely go into much more on this later on. But it was things which I've never heard before. It was very interesting. Thanks again so much. Thanks to our secretary, Dr. Gaddi Divakar. And thanks to all our viewers. Long live ASI.
Thank you
Yes,
very
madam.
much.
You said no military discipline. That's what it is. 1 hour. Time means time. Yes.
Exactly.
Sorry.
I was just listening. It was just 12 minutes each and stop. Thank you all so much.
Thank you.
Good night, everyone.
Thank you.
Thanks.
Thank you.
Thank you very much. We'll meet next week, same